be on? Can people hear me?
Raju, what we'll do is once you're on, we wait for a few minutes for people to join in, so we can be on mute mode for some time.
Okay, no problem.
Yeah. Good evening, everybody. We're just going to begin in a moment's time. So I'm just giving some instructions. We will wait for another 2 to 3 minutes for people to join in. Thank you for waiting. We have around 30 participants. I'll just wait for a minute and then we'll begin, Dr. Raj, if it's okay. Good evening, everybody. Welcome back to the yet another program on OSCEs and related training. Today we have distinguished faculty, Dr. Raju. Dr. Raju has actually done his MD Psychiatry from NIMHANS, and he happens to be my senior, and we were there for around 1.5 years together there. Dr. Raju right now resides in Australia. He's the Director of Training for Victoria, and he's also Additional Director of Psychiatry there. He's very keenly interested in doing training, and he's actually trained a lot of our colleagues who go from Bangalore or from India to go through the exams of Australia and New Zealand related boards there. So he's quite proficient on and also quite familiar with the use of OSCEs in terms of psychiatry training. Dr. Raj has agreed to be with us today. He's also prepared this 25 sets of questions that was presented in the last Saturday. So today he's going to discuss a few aspects of how to go about answering these sort of questions. He's also free to take in any questions related to OSCE and related matters for training. So his chat box is going to be open. So as and when you shoot in questions, he's also going to take it up. Thank you, Raju, for agreeing to be with us. Over to you, Dr. Raju.
All right, thanks, Mahesh. And good evening, everyone. It's about 9, so I may sound a bit slow and tardy. It's my usual bedtime, but probably works best. Now, I really wanted to sort of spend some time with you all to try and get your understanding about what's important in being successful in exams. Because as Mahesh described my role, I'm the director of training for people who come from abroad, specialist international medical graduates, and practice psychiatry in Melbourne. There are about 80 of them. And in my interactions over the years with people who have pre-MD, post-MD, and those who come across and do other exams, I have sort of some ideas which may not totally sit within the knowledge of psychiatry. So I wanted to just get you guys to think about, some fundamental principles about what is important to pass exams. So can people just key in some thoughts in the chat box? I can't see you all, but I'll know what you're thinking. And the reason I say this is very important. I think we should not forget the forest for the trees, and when you look at exams, it's very easy to look at it singularly as a set of questions or tasks that you have to complete. But that's not the purpose of the exam. The purpose of the exam is to understand what you have learned in your training and whether you can perform as a psychiatrist once you complete the particular set of exams. So someone's written practical knowledge, how we deal with patients when we start practicing. Okay, yeah, so the exams are a reflection to some extent of your practice, which is a very good point, and we'll talk a little bit about that. So do you all think that exams are actually reflections of your practice, or do you feel sometimes questions in exams can be a bit further away from how you practice? Yeah, Angeline's written ability to perform under pressure. So exams in all countries, anywhere, often are time limited, and there is a pressure to deliver in a time limited sense. And in many exams, there is either an observer who's sitting there or someone who's going to correct you. So you always get judged, and it's not a nice thing to feel judged. So there's always an element of pressure and a sense of being observed or judged by somebody. Upasana's written, they are often simply a reflection on how well we have prepared for that particular exam. I'm not sure whether they are or not, because a very well-prepared person may find exam very daunting and may not probably even pass the exam. So I don't know whether just preparation in terms of knowing things is equal to doing well in exams. All right, you all must be pretty tired today. Getting really slow responses to something which is a bit broad. I don't mean to sound, non-scientific, but as an educationalist, and if you look at educational research, there are some key points that are really important to understand. So one of the things that I tell my trainees when they prepare for exams is to be able to see the exams from the eyes of the examiner, because they are the ones who are going to mark you to pass or fail. So it's really important to understand why certain things are done or expected, why some questions are asked, and what is expected out of that. Most countries these days sort of talk about something called CANMEDS. It's a framework that defines a medical specialist. It has its origins in 2001 in Canada. And what CANMEDS basically looks at is whichever postgraduate exam someone is being assessed for in, that would allow them to become a medical specialist. They basically feel that exam has to focus on assessing the various domains of CANMEDS. There are about, I think, 8 domains, if I'm not mistaken, in CANMEDS. The first and foremost is one of a medical expert, where there's an expectation that you are quite strongly grounded as a medical expert in the knowledge of psychiatry. Then there are the other domains, which I call the silent domains, but do have a lot of influence on how you perform in exams and how you come out at the other end. So these domains are things like professional. Do you have some degree of professionalism, which includes things like ethical behavior, being respectful, being a therapist or a practitioner who values other human beings and maintains their dignity, those kind of aspects. Then there is the domain of being a manager, where you're able to take some aspects of resource management and population health into perspective when you make certain decisions, and being able to look at it from that perspective, as in how do you, if you suggest some treatment, how do you actually make it happen? It's not just suggesting, but also making it happen. So for example, you may think that somebody with, say, treatment-resistant schizophrenia may be a good candidate for clozapine. But if they're based in a very tribal area, it may be really hard to commence clozapine. So you may have to think about the practicalities of it and think about what resources are there and how do you make it work. The other domain is a collaborator, which is your ability to engage other specialists, other disciplines, and try and harness their expertise to be able to design a very elaborate biopsychosocial management plan or understanding of the patient. So collaboration also involving patients in some of the decision making that happens, and taking their point of view. Okay. Then you have a scholar, who is someone who is the domain talks to whether you're well informed about literature and you're able to translate that literature around research into practice. So it's good to be informed about literature, as in a very bookish sense. And if somebody asked you what are the key outcomes of KT study, being able to talk about it when asked versus being able to apply that knowledge in your practice, where if you have to explain how you chose an antipsychotic to treat a patient, bringing in that information to explain your decision making is what a scholar does. And then there's a domain of a communicator who's able to communicate in a very succinct way, in a very distilled way, their thoughts around a particular topic. And that is often assessed in time-limited viva voces, oral presentations, or sometimes even some of these case vignettes that I have put up for you, which want to get to the heart of things very quickly in a time-limited way. So I think they are broadly the ones. I might have missed a few, but it's end of the day. But if you're interested, look up CANMEDS competencies for medical specialists. It's quite important. So I think like one of the things that I feel it's important for you all to know is that people are examined with all these frameworks in mind. It's not just how well you read a particular textbook or whatever, and how you just regurgitate that information. And for that reason, OSCEs have become very popular because OSCEs stand for Objective Structured Clinical Examinations. So here, what they want to see is how do you apply this knowledge in a clinical scenario, and whether you're able to sort of prioritize information, are you able to present information in the most succinct way, and think like where your consultants would be thinking, because this exam is the threshold to become a consultant for most of you. Okay. So it's really important to sort of understand what goes on in examiner's mind. So I think to sort of in some ways to put this in context of what I asked, I think a lot of times we struggle to actually practice what is best practice. And that's for various reasons: resources, where you work, access to means and methods. So I don't necessarily think that exams totally assess what you practice. Exams really want to assess what you should be practicing in an ideal world, and then being able to sort of temper it with how resource limitation can affect real life practice. Because most exams in most countries for postgraduate studies are about making sure you know what's the best practice, but also that you know what is applicable to your patient group within the resources that you work in. The second big issue that affects people in exams, and it's really important to talk about it and deal with it before you suffer and succumb to it, is the anxiety. It's a global issue. Most exam analysis have shown that about 30 to 40% of candidates perform poorly due to situational performance anxiety. In that group of people, a significant number of them have untreated anxiety disorders or some other kind of high prevalence mental health conditions. And I can tell you that in every country, medical practitioners are very resistant to seeking help and dealing with their own problems. So my advice to each one of you is to really introspect. And if you feel that you're the sort of person who gets anxious when put in a spot, you stutter, or you start your heart feeling that your heart's beating really fast, or you're sweaty, and you feel that you know stuff but you can't communicate because you're so tense and you worry whether you're going to make a mistake, please do talk to someone whom you trust and go and seek help. A lot of this is quite normal. It's a very high stakes exam. You don't need to have a mental health disorder to feel that way, but some of us have the outliers in the normal anxiety spectrum. So remember that anxiety is a huge modifiable factor that can affect your exams. The other thing that affects your performance in exams, especially in India, I feel, which is interesting, is that I know from my own experience, knowing my colleagues and having gone through medical school and MD, that a far majority of people may not be fully English medium from their year 1 to year 12 in medical school, and the competency in English may differ. And these exams are unfortunately only in English. So sometimes one of the barriers is to be able to, when you're put on a spot, your tendency to think about that particular issue and process information is English to your mother tongue processes back to English. So there's a bit of a time, sort of extra time that happens. So in some ways, practice is good. And in other ways, I think it's really important to ensure that if you don't have a nice handwriting, to work on it, because if your handwriting is unreadable, you don't get marked. And if your presentation is incoherent or difficult to understand, then you get marked down. So these are some of the important soft skills that you need to work on before you sit the exams. I know that time is always an issue, but I'm hoping that even being aware and conscious and making a little conscious effort in addressing these issues may help in you guys doing better in these exams. Okay. So as I said, the OSCEs have to be, they are clinical exams. They're often structured, so it's the same question for everyone, and that avoids any kind of variability. However, a lot of times, or in majority of the situations, OSCEs are also observed or involve a clinical interaction, which is what I felt was a little odd about these exams, where what you were, as in this 25 stations that was set, were predominantly going to be a written response to a question. So it's almost like a written paper split up into 25 pieces. So when Mahesh actually spoke to me and sent me the PowerPoint from the DNB, introduction to these exams, I had a look through and I said to Mahesh, these look like more like in Australia and New Zealand setting, there's a section in our written paper which is called key feature questions. So they give a clinical VNet and ask a question, but ask you to list 1 or 2 or 3 key features. What this section would specifically focus on is your ability to synthesize the information, think about various options, then being able to contextualize those options to that case VNet at hand, and then present the most important findings based on your frontal lobe functions. So what this key feature cases or scenarios are doing is testing your frontal lobe function and a degree of your memory in terms of facts, but it's really application of facts. So that's why they're quite a good set of questions, because it's not about just knowing, it's about knowing when to and how to. Okay. So, but unfortunately, all these stations, my sense is that you'll be given a booklet and you write your answers and they get scanned and somebody corrects it. So these questions are pretty standardized, like in any written paper. But the difference is that you get 5 minutes to attempt each one and you can't go back and revise your answer. So it puts you on the spot in some senses. The traditional OSCE stations are where you are performing a clinical interview or a clinical scenario, and somebody is observing you and the examiner then marks you. Some of those clinical situations, there would be an aspect where you have to interact with the examiner in form of presenting your findings or discussing a particular issue that is outlined before you entered the station. Okay, so a lot of MRC Psych and in College of Psychiatrists here, we have OSCEs as part of the exit clinical exam. And these OSCEs are generally of 2 forms. One is a 2-minute reading time and 5-minute performing time, or 2 minutes and 7 minutes, or it could be 5 and 15 minutes, the long stations. Okay. So, I think you have a couple of those components, but they're not too many. There are only a few from reading of the information that's been sent to me. Any questions till now? Any comments, questions? Is this useful for you all to know about this background? All right. Okay. All right. Thanks. Yeah, I don't want you to feel like I'm wasting your time, but I really think it's important to say this. I don't know whether they've kind of anyone's told you this, but as an examiner and also as a trainer, these are things that really matter. Knowledge is important, and I'm pretty sure all of you work really hard and read your books, but to translate knowledge into passing, you need these other structures to scaffold that process. So look, we'll go to the set of questions that I have sent you. To be very honest, I cut and pasted from my previous exams in Australia that have something called key feature questions or short answer questions. So it was 45 minutes of cut and paste job with some modification of names and scenarios, because I know that there are things that are maybe a bit different to Indian system. So you might have felt that some questions may be a little bit not really here, but that's the case. That's because they were cut and paste. So the other reason I cut and paste is to preserve the integrity of the answers. So when we kind of go through the answers, we know why that answer was recommended. Again, I just want to let you know that these sets of questions are just examples. They're mock. In a true exam process, everything gets vetted out very in a lot of detail. So there's a panel that I really don't know about DNB exams, but in College of Psychiatrists here, we have a panel that teases out each and every question. We all attempt the questions independently. The variation of responses are all discussed, and if something is too controversial, we remove that from the paper. If it is all agreed upon, that is retained. So there's a lot of calibration that goes on, and I'm pretty sure there's something like that happens. Otherwise, they're open to criticism. So I'm going to share my screen, and I think the way it would be useful is, I'm not sure whether you all got your key and you've gone through your own questions and marked yourself. But what I may do is run through the questions, but get you to stop me to if there's any query about any particular scenario, because I'm not a specialist child psychiatrist or a particular psychiatrist. My knowledge is generalist, so there may be some questions I can explain in detail for you. There may be some questions I might give you a brief understanding and then get you to go and talk to a specialist around it. But one of the things that is true about PG exams is, if I sat your exams tonight, I would probably flunk it, because there's a lot of stuff that is, there's a gap between that learning that you do when you're a PG to when you're a practicing psychiatrist. So, Mahesh, did you have anything to add or say?
No, go ahead, Raju. Basically, they wanted to see how you had actually thought about the responses to be, and for them to be marked appropriately, I thought your inputs were best.
Okay, all right. Let's get there then.
Probably you could take a few scenarios. There are 25, right? So you could take a few scenarios.
I'll just take a few. Have they got the key? You distribute the answers?
Yes. Whatever you had sent is forwarded to them. They all have the keys also.
Great, fantastic. So I'll just do a custom slideshow. Okay, you can see my screen. If not, just give me a second. That's a bit All right, we'll share that. All right. So we started off with Mahesh because it was easy to think about a name. But look, this is just a kind of question to try and understand what are the two key areas you would look for in Asperger's. My chat has disappeared. Let me get the chat up. Okay. I'm just keeping the chat on. So look, if you have any comments, just stop me and we can just go through it. But this is pretty straightforward, and some of it you have to understand that these questions are from 2006, so it's about 14 years ago. DSM-4 has moved on to DSM-5, so and a lot of controversy has arisen over the term Asperger's. Are you aware of that? That now people are not called Asperger's anymore, and do you know why? Anyone knows that? So if you didn't know, the term Asperger's came from a person whose name was Asperger, and he was convicted for child sexual offenses and child abuse. So in a retrospective way, when the historians look back at some of the allegations, and for that reason, people don't actually use the term Asperger's anymore and they just call it autism spectrum disorder. Yeah, so that's the reason why Asperger's is not used anymore. There's a degree of, political correctness to it. All right. All right. The next one is a kind of a forensic one, but also getting you to think about what's the first thing you do in somebody who is presented with recent onset psychotic symptoms, and what are the things that come to your mind straight away? The key seems to be pretty reasonable. So thinking about organic conditions would be number one. Do you all know what a fool's hierarchy is? And if someone knows what it is, can you key it in? Okay. If you guys don't know what a fool's hierarchy is, you might want to chat to one of your consultants or Mahesh. Probably Mahesh remembers fool's hierarchy from good old RSP unit days. So fool's hierarchy is a way in which you consider a differential. And number one, always that you have to consider is this presentation related to organic? Okay. So fool's hierarchy starts from organic, then it goes to mood disorders, then it goes to psychotic disorders, then it goes to neurotic disorders. So it's a bit of a pyramid in which, look, yeah, again, I think it could be brief psychotic disorder, but this you have to just consider that this one is a DSM based kind of a thing. So in ICD, acute and transient disorder would be something that is very likely. So I would think that that may be an accurate way of thinking about it. So the symptoms is two statistically most likely differential diagnosis. I think it would be one, a drug-induced psychosis, definitely, and if you want to use acute and transient psychotic disorder or a brief psychotic disorder, both would be fine. Yeah, I agree that it's not a schizophreniform disorder if it's only 2 weeks. But having said that, I just want to read Okay. All right. Let's move on. That's okay. Sorry. Again, this one, I don't think we should pay too much attention to that. I actually, after I I sent the question on reflection, I thought maybe atypical depression is something that may not be all that popular in India. But if it was atypical depression, I think looking at the symptoms that you need to look for, those would be reasonably accurate. So is there, like, are you all familiar with atypical depression and reverse neurovegetative science? Okay, good. All right. So yeah, occasionally you may have patients present with atypical depression, and can anyone sort of tell me, I know it's not accordance with ICD, that's why I said on reflection I might have chosen to maybe not give this, but look, anyone sort of have any ideas about any preferred group of drugs in atypical depression? Historically, there was some suggestion that certain group of antidepressants work better. Yeah, that's right. But do you know what's the update on that? So monoamine oxidase inhibitors were considered to be the first choice for atypical antidepressant, atypical depression, because they were slightly more activating. Having said that, the research later on showed that there was no significant difference between other antidepressants and MAOIs. And you don't want to use MAOI because of its adverse profile. So, you know, it's no longer believed so. Okay. This one about someone presenting to community mental health center or your clinic with suicidal thoughts and disclosing that they've taken some medications before coming in. You know, so this is a pretty straightforward one. Again, you know, I think in your case, you just rush her to ED and whilst waiting for someone to take her there, or you want to get as much information about what she took and how much so you can hand it over to your physician colleague. So this one is ICD Diagnosis of Delirium. So you all kind of comfortable with? Yeah, I think this is a pretty straightforward one. I think the way this sort of scenario could be presented to trap you all could be the question saying that all the findings are normal in a 73-year-old man with a history of fever a week ago. But if they have those clinical symptoms, delirium is a clinical diagnosis. It's not a pathological diagnosis, as in it's not a diagnosis based on investigations. So being really aware that delirium should be considered as number one in anyone who is older than 60, 65, and who has some comorbid medical condition and there's an acute deterioration is absolutely, absolutely important. So apart from delirium, the two most important potential psychiatric yeah, look, I will tell you that answer there is wrong. So I'm just having a quick look and telling you what they wanted to know. Yeah, I think the two most important differentials or comorbidities they wanted you to consider, and this is something, again, old age psychiatry, is whether this is acute or chronic, which is so delirium and dementia. So there's a term called acute on chronic, which worth looking up, especially in old age psychiatry, and if this is a missed withdrawal syndrome. So delirium-like picture, but the delirium is induced by substance misuse. Substance misuse or dependence is quite underestimated in older age people, especially those who have pain issues, and they tend to become quite dependent on pain medication, and some of them on alcohol, some of them on benzodiazepines, often prescribed medications. And when they present acutely, one has to really take into account. Sorry, I should have put all panelists in. Yeah, anticholinergics. Oh. I don't think anticholinergics would cause, unless someone's prescribed that. In a delirious patient that you don't know very well, and you've not prescribed anything, I think you should keep the thought of some substance withdrawal sort of thing open. And again, this is not, it depends on the context. So this is from obviously Australian, New Zealand context. In your context, if somebody's in Bangalore, yes, you can consider substance withdrawal. But if somebody is is part of a Buddhist monastery and is a monk, I think that will be not your first sort of a thing. So this is a question about Indigenous mental health, as in, like, I think in Australia, Indigenous population is quite a specific vulnerable group. And I think in India, you do get people from remote areas or from different cultural backgrounds coming into your clinic. So I just put the question there to get you to think about cultural psychiatry, transcultural psychiatry, and being able to use a cultural advisor or a liaison officer is really, really important. Often the assessment is inaccurate unless you use someone who can translate or interpret in person's language. So that's kind of, and in any aspects of assessment, one of the important things is risk assessment. This was not particularly very well taught to me when I was in NIMHANS, because culturally it was not acceptable to self-harm or lash out at people. But in the last 20 years, since I go and come back to India, I think now it's pretty relevant to India, with all the media and everything. Everyone has access to all kinds of cultures and responses and modeling all those kind of complicated mechanisms. So important to assess for risk these days. I usually put my risk assessment next to mental state examination so that I never forget. And it's absolutely important you develop some mechanism to remember. Okay, this is just a question about somatization disorder, and I put yes, no as the advice you would give to the GP. It's pretty straightforward. There may be some little controversy, I would imagine, on whether you start an SSRI or not. Generally, it's preferable that you assess a person, and only if they have comorbidities you consider, antidepressants or SSRIs. Somatization by itself is quite difficult to treat condition and often responds better to psychotherapy. Okay, this is again bipolar disorder and perinatal. are you guys good with, drugs that can be used in perinatal group of patients, pregnancy, lactation, especially bipolar? How would you manage a patient with bipolar disorder who's on lithium or sodium valproate and are wanting to get pregnant or have gotten pregnant, and in postpartum period? Yes, I shall take the silence as agreement. So I'll keep trudging along. Really, really important to note in, in bipolar, sleep is absolutely important to prevent recurrence. Very understated in hospital-based training. But if you were to follow a bipolar patient, there's always a correlation between sleep and recurrences. And it's really important to understand that the risk of person becoming psychotic and therefore either losing the pregnancy or unable to perform the parenting role is very, very high, and risk of then the risk of treating that. In fact, treating it is more helpful. So somebody raised their hand. I think Ponguri, do you want to just quickly type something in? No? Someone hit the button by mistake? All right. Sorry, this is a bit one-way traffic. Don't know about India, but I would assume, given what I watch on TV and Bollywood, that eating disorders become a big issue in India by now. When I was training, it would be like a couple of eating disorders in a year in NIMHANS, and we all would really want to go and interview them and talk about them and discuss in case presentations. But I'm pretty sure it's all a bit more sort of prevalent. Really important to know what are the criteria to admit someone. Absolutely important. And also to try and understand the treatment approach for people with eating disorders. The binge eating disorder has become quite a big issue in most countries. It starts off by comfort eating and then later on goes on to become a binge eating disorder. And it is obvious in binge eating disorder, it's not associated with purging. So it's not bulimia nervosa. So if you're not brushed up on eating disorders, please do. Often one of the agendas for examiners in these exams is also to ask about topics that usually are not covered in your clinical placement. Are you, in this scenario, you're saying suicide prevention, is it? I think that on one occasion, threatened to kill herself if her mother made to eat is more seen to be like a fear of whatever she believes will happen rather than something that you want to like think that she'd act on it. You definitely need to consider that, but I think most of these sort of things is about, so list the most important reasons to admit Kelly for inpatient treatment. So often the criteria for admission in an eating disorder patient, anorexia nervosa, are usually related to their physiological risks and risks of imminent death due to medical conditions. So is actually a very good, if you go to Google and Google guidelines on eating disorders, there are few, and some of them have really good tables about indications for admission and stuff like that. There's one on College of Psychiatrists in Australia, a guideline which is pretty useful if you want to have a look at it. Let's skip this. This is a bit too dense. So managing adverse effects of SSRIs and adverse effects of SSRIs on sexual functioning, quite important question. There's quite a high prevalence of sexual side effects, both in men and women. So important to know about it. Often people don't really ask in clinical practice, and sometimes I think if you make a habit of asking, you'll be surprised as to how many people actually report that. So risk factors for suicide. Suicide is a hugely important topic in India and across the world. So it's really important to know risk factors for suicide, high-risk groups that get affected by suicide, and what is your approach to someone who is suicidal or self-harming. If you don't have an access, please Google again. There are a lot of clinical practice guidelines in managing self-harm and suicide. The most important construct I want you to sort of look at and think about is something called a safety plan. It came out of the research that's been done in veterans and later on in other suicidal populations. And it's a very simple tool and very effective management of looking at how do you help someone self-manage some of the suicidal impulses. The framework in which you manage somebody who is suicidal is quite important. That is articulated well in the guidelines. And part of it is about assessing their level of social support and the protective factors that they have. So please do have a look at it before your exams. It can be asked. Alzheimer's in people with dementia, Down syndrome, that's reasonably straightforward. And again, Alzheimer's disease is a biggie in exams. You need to know everything about Alzheimer's pathophysiology, treatments, the BPSD, which is the behavioral psychological symptoms in dementia, and how do you manage them. Okay. This is another bipolar, and this is very much a facts question, so unusual, but people can slip something like that in. Psychotherapy. Now, I put this in intentionally because I sit on the state assessment panel here, and we get a lot of applicants from India and subcontinent. And one of the big deficiencies in most of your training is psychodynamic psychiatry, is psychodynamic psychotherapy. I don't think it's relevant for your DNB exam. I don't know whether they're going to go into that much detail. Probably they'll ask you more about Beck's triad of depression and cognitive behavior therapy principles. So don't freak out. I just put it there to freak your guys out, really, not intending anything else. And you will find those red herring questions in your exam. So out of the 25, 16 will be pretty straightforward. Everybody would know something about it. There'll be 7 that will be kind of slightly difficult, and they'll be the ones that are called the discriminating stations. That will discriminate somebody who's studied and prepared well versus somebody who just kind of thought, all right, I'll give it a go. And there'll be 2 red herrings, which nobody will know what the answer is, but there'll be enough space where it can throw you off. So the best thing in these exams is you find something is difficult, 5 minutes spend on it, and then just get it out of your head. And that's the most important thing. If you let it linger on and haunt you, you'll destroy the rest of your paper. Okay? And most important when you prepare for exams is to focus on the 16 plus 7, not the 2 that nobody can answer. Rapid cycling, I'm pretty sure you all are across rapid cyclers. But again, bipolar spectrum disorders, bipolar disorder, rapid cycling, ultra rapid cycling, very common questions. Need to know, read your guidelines. Try and when you have some scenarios like this, try and see why they gave that information 50 years of age, and lithium carbonate, what do they mean before answering, because it's important to contextualize. You want to know that as people get older, people's renal functions get affected, their thyroid functions get affected. So you really don't want to use something like lithium at that age. You need to start thinking about shifting to something else. 50 also signals maybe end of reproductive age group. So maybe now you can think of sodium valproate. So things like that are important to consider in answering these questions. I think we got just a minute left. So any questions, because I'll stop here and I'm happy to open it up for any questions before we conclude. Comments are also welcome if questions are scary. Comments are very welcome. All right. Again, silence is agreement. But look, all the best, and hopefully, I think should answers always be matching exactly with the key to score. Look, in this OSCE, they're always going to have a key, and that's the only way they can standardly mark people without stressing out too much. So I think it's really important to try and get there. Look, there's always going to be like in the key development, sometimes even though they say you have give 2 points, they may have a key that covers 5 points and they'll give you equal marks if you got something. But there may be one particular element of the answer that has more marks than the other. All right, Mahesh is going home. How to approach and improve on psychotherapy questions.
Don't worry, I'm on.
I know, but I don't want you to be driving and looking into Zoom, Mahesh. We don't want to see any accidents on the screen.
I'm stopping, don't worry.
All right. Look, psychotherapy, your questions would be on cognitive behavior therapy, interpersonal therapy, and exposure response prevention. If I were an examiner for Indian scenario, those would be the 3 topics I would drill you on. Rest is good to know, especially things like EMDR. For PTSD, what are the 2 psychotherapies that are indicated in PTSD? You go EMDR, you go trauma-focused CBT. All right. So I think, but you need to know details of CBT, IPT, and exposure response prevention. Topics in neurology. Look, there could be questions about Parkinsonism, questions about, all the, if you pick a Leishman, things like key findings in Lewy body dementia, So all those things are very much part of these kind of OSCE stations, because as I said, these are not true OSCEs, they're key feature questions. So anything that you have easily reproducible key features, they can ask you. So Wilson's disease, key findings in Wilson's disease, that could be a question, or the tests you do to confirm certain thing. Yeah, there are lots of questions of personality disorders, especially borderline personality disorder. And I think my sense is that's emerging in India. And I say that without knowing what is there in India right now. But at least when I was training, it was not all that common. But if you want some really good guidelines, there's a website called Spectrum, and it is the statewide specialist service on severe personality disorders, and they have very good resources. Okay, I think.
Yeah, thank you, Raju, for taking us through for the last 1 hour for reorienting the preparations for OSCEs. And I think good that you are able to give us scenarios and actually take this time out to come and actually discuss important scenarios of some questions at least, so that they understand what the examiner expects when they're actually attending an exam like OSCE. We just had a meeting and discussion with the national board. So basically, what they're going to do is have 25 stations, which is going to keep getting displayed on the PPT format. They're all going to sit in an exam hall with social distancing format. And at the end of 5 minutes, the answer script for each question will be collected back. So there'll be 25 sheets for one student, and all these things will be compiled and sent to national board in the scanned format and also the hard copies. So the best part is, like, you're preparing for 200 marks, trying to prepare for these 25 stations. Even if 1 or 2 stations go bad, actually really will not affect the scores. And the rest is vivos and 2 case discussions. I think in the last 3 years of training, they're really tuned to this form of assessments. And the best part is 200 marks is OSCEs. So I'm damn sure that every one of you have a very good chance of passing. Even a consultant who had given the exam 20 years ago has a good chance of passing this exam, because there are 200 OSCEs, 200 marks of OSCEs worth here. That's what I was thinking.
And the better chance of passing. So if you had only 10 and more marks on each one, the weightage goes up on each station.
I was also looking at the other scenario. If OSCEs were only 100 marks, if they had added 3, actual clinical case discussions, added little more weightage for the Viva, it would have brought down the pass percentage, simply because there's a lot of objectivity would have been brought down, and the marking could be very different. So, I think this is the best way. 200 marks for OSCE and 100 marks for the rest is a beautiful scenario.
So when is the exam, Mahesh?
11th August.
Oh, okay. It's around the corner.
Yes. So I'm actually thinking, if you look at the pass percentage of practicals in the past, and in the last 10 years, if you look also, it would be just 20%, 25% maximum percentage passes. I'm told in some other subjects, because OSCE is introduced, they've had 100% pass. So COVID has got a very good advantage, and students must thank this COVID times. They've changed the whole format. Otherwise, DNB would have been so resistant for any change. This is the best time for all of us to give an
exam. That's good to know. And I hope you would get a sense of when you answered this. I think if all of you got anyone who's corrected 50% and over, I think you do really well, as in you'll get much more than what you get in this, because I've not altered the stuff to suit the Indian scenario. So you probably would do a lot better if those questions were altered. So I think the most important thing is being able to move on when the station moves. Don't let
Another thing, Dr. Raju, here, what's going to happen is once the scenario is played and answer papers are given, at the end of 5 minutes, the scenario changes, the paper is taken away. So don't have time to revisit the previous scenario. We cannot replay the scenario, nor can we get the answer paper to write something. So it's done. Yeah. At the end of 5 minutes, you're done with it and you have to move on. There's no other options.
Why are they wanting to collect the papers? It'll be such a hassle, people running around the room and all that. They could just let a booklet and move
No,
on.
what they've told us is like, they're all going to sit in their respective chairs, which is going to be called stations. There's no loo break also. You have a loo break before you start the exam. At the end of 2.5 hours or 3 hours, you get a break. Otherwise, they're not supposed to move around. And there's going to be a camera in the front, from the behind, to make sure everything is really conducted as per the good practices of examination. So they will be watching live. So no students is allowed to move out. He has
People
to be in
can
the
take
chair.
the Human Rights Commission violation of human rights not to let you have a loo break.
Violation for the 3 hours duration, definitely.
All right. Good luck, everyone. And hopefully, in some small way, the mock exam helps and gives you confidence to do well. All the very best.
Yeah, thank you, Raju, for taking this time off for our students. Really appreciate your gesture. As a part of the Steady Arogya series, we were running it, and good we are able to find important faculties across who are actually well versed with OSCEs. Thank you so much for being with us.
No problem, Mahesh. Bye.
And as far as the students is concerned, I'm trying to set up another mock exam. I've requested one of my colleague to do it. He's amidst his preparation, so he's finished only 10 questions. So I asked him for 15 more. Probably we will have the question, the mock exam on Sunday or Monday. We will intimate you. It's good to give more exams just to make sure you get away the nervousness of giving an exam. So we'll try and simulate more exams for you. Till 11th, we have another 12 more days time. So we will try and run as many questions as possible. Okay, I think we'll cut short the theory discussions, but we'll run exams for you. Okay, thank you, everybody. Thank you, Raju. Thank you, Sriram, for staying tuned for all our series and having seamless technological connectivity issues are all sorted out with you. Thank you so much. Thank you, Raju, again. Thank you, everybody. Have a nice day.